Good morning, everyone. I am Teresa Tsang. I want to thank the organizing committee for inviting me. I have no relevant disclosures. I was asked to talk about assessment of the atria. We'll start with left atrial structure, function, and physiology, why it is clinically significant to assess left atrial size and function. Then we will talk about how to quantitate left atrial size and function. And finally, we'll finish off with assessment of right atrial size and function. The left atrium is a fascinating structure. It is a highly dynamic volume sensor. It responds to stretch with secretion of atrial natriuretic peptide, which promotes vasodilatation, natriuresis, and diuresis. These effects counteract the actions of the renin-angiotensin-aldosterone system, which promotes sodium and fluid retention and vasoconstriction. The left atrium modulates left ventricular filling through its function as a reservoir during left ventricular systole and as a conduit for the blood flow from the pulmonary veins to the left ventricle during early diastole. It is an active contractile chamber that augments left ventricular filling in late diastole. This atrial kick contributes to about 30% of the cardiac output, and it also acts as a suction pump that refills itself in early systole. Left atrial size is a barometer of diastolic function. As shown in this study, indexed left atrial volume correlates well with diastolic function grade. In persons without history or evidence of atrial fibrillation or mitral valve disease, the larger the left atrial volume, the more severe the diastolic dysfunction by Doppler. But increased left atrial volume is not all about the severity of diastolic dysfunction. It provides additional data on chronicity as reflected by the degree of structural remodeling that has already occurred. In this study, left atrial volume greater than 28 ml per meter square was 87% sensitive and 93% specific for identifying the presence of diastolic dysfunction by Doppler. Index left atrial volume also correlated well with left ventricular filling pressures as measured by tissue Doppler EE prime, as shown on the right side of the slide. The importance of left atrial volume in diastolic function assessment was recognized and included in the most recent diastolic function guidelines as an upfront criterion for determining if diastolic dysfunction is present or not. The left atrium can be likened to a crystal ball, informing what will likely happen over the next few years. Left atrial volume has proven itself to be easily the most powerful predictor for first and recurrent atrial fibrillation, first and recurrent stroke, development of heart failure, both in the context of preserved and reduced ejection fraction, coronary artery events, including myocardial infarction and need for revascularization procedure, as well as post-MI survival. It predicts the likelihood of staying in sinus rhythm after cardioversion and atrial fibrillation ablation. It is a robust predictor of cardiovascular and all-cause death. In this study, we evaluated 1,160 persons age 65 plus, all without the primary events of interest, including first atrial fibrillation, first stroke, first myocardial infarction, first revascularization, heart failure, and cardiovascular death. What we found was that left atrial volume greater than 30 ml per meter square was independently predictive of these events, independent of clinical risk factors, diastolic function, ejection fraction, and left ventricular mass. Left atrial volume is a potent predictor of cardiovascular events. In a study of 840 persons with no history or evidence of atrial fibrillation or valvular heart disease, we found that indexed left atrial volume was incremental to diastolic function grade for the prediction of first atrial fibrillation. Those persons with left atrial volume in the upper tertile with indexed left atrial volume 37 ml per meter square or greater had a 20% risk for developing first atrial fibrillation within 5 years. On the right-hand side, we are showing that left atrial volume was also predictive of first heart failure in patients with well-preserved ejection fraction. In fact, left atrial volume greater than 32 ml per meter square was highly predictive of first heart failure. Those with left atrial volume in the upper tertile of 37 ml per meter square or greater left atrial volume had a 17% risk of heart failure over 5 years. This heart failure study included 610 patients with ejection fraction less than 35%. Left atrial volume was highly predictive of death or heart failure hospitalization. On the right is the hazard ratio for death or heart failure hospitalization. Each ml per meter square increase in left atrial volume beyond 26 ml per meter square was associated with an extra 7% risk of death or heart failure hospitalization. Left atrial volume is a powerful predictor of survival post-acute myocardial infarction. The larger the left atrial volume, the greater the risk of death post-acute myocardial infarction. Left atrial volume greater than 32 ml per meter square independently predicted 3-year mortality, incremental to clinical risk factors, ejection fraction, and diastolic function parameters. Each ml per meter square increase in left atrial volume was associated with an additional 5% risk of dying. On the right, the Kaplan-Meier curves show that post-MI 2-year survival of patients with the highest quartile of left atrial volume was only 50%. I have used the generic term size, which can mean one-dimensional diameter, two-dimensional area, or three-dimensional volume. These are the RLC curves comparing the performance of left atrial volume in blue, left atrial area in yellow, and left atrial diameter in red for prediction of first events in 317 patients, all in sinus rhythm at baseline. The events of interest were first atrial fibrillation, first stroke, heart failure, revascularization, myocardial infarction, and premature death. Left atrial volume was the most robust predictor and provided better discrimination than the other two measurements. This is hardly surprising. When the left atrium enlarges, it does not enlarge symmetrically. Linear dimensions simply cannot capture the changes in size of a three-dimensional structure. In most echo labs today, left atrial volume is assessed by biplane Simpson's method or biplane area length method. Irrespective of which method, these guidelines on the right still apply. First, optimize left atrial visualization. You want to maximize the left atrial area without foreshortening the left atrium. You want to adjust the gain to ensure best visualization of the endocardium. You need to optimize the timing as well. For maximal left atrial volume, you choose end ventricular systole, essentially at the end of T wave, just before mitral valve opens. Sometimes you have to scroll back and forth to open and close the mitral valve. The optimal time is immediately before opening of the valve. Then trace the left atrial endocardial border, with one border being the plane of the mitral annulus. Make sure you exclude left atrial appendage and confluence of the pulmonary veins. For biplane area length method, planimetry is the same. The length is midline perpendicular to the plane of mitral annulus. The two lengths should be less than 5 millimeter difference, as you are really measuring the same distance, only from two different angles. There had been a lot of debate about using the longer, shorter, or average of the two lengths. We use average of the two lengths. The key is to check to make sure that your lengths from the 4-chamber and the 2-chamber views are within 5 millimeter difference. It has been recognized that the long axis of left ventricle does not line up well with the long axis of the left atrium. You need to make sure that there is no left atrial foreshortening so that you are maximizing the left atrial area for planimetry. On the right-hand side, I'm showing you an example of what happened if you don't use an LA-centric view. The standard 4-chamber view gives you left atrial volume of 47 ml, and by using the LA-centric view, making sure that the left atrial area is maximized, the left atrial volume measures 67 ml. Left atrial volumes should always be indexed to body surface area. Normal is 34 ml per meter square or less. The upper limit of each category is 7 ml per meter square more than the upper limit of the last category. Hence, 34 plus 7 is equals to 41, plus 7 is equals to 48. Do remember the fact that there are inherent geometric assumptions of biplane left atrial volume. The left atrium is a far-field structure and it's easy to get foreshortened. There are data showing that 3D left atrial volume is superior and has lower test-retest variability. So is 3D left atrial volume better than 2D left atrial volume? The data certainly suggests so. This prospective study of 92 patients who had cardiac MRI, 2D biplane area length left atrial volume, and real-time 3D left atrial volume by TomTec showed that 3D left atrial volume is correlated with MR better, with a correlation coefficient of 0.93, which is superior to correlation coefficient of 0.74 for 2D. They also found that the 2D method systematically underestimated left atrial volume, whereas biases with 3D were said to be negligible. Using a threshold of 34 ml per meter squared to define abnormal left atrial size for all three modalities, agreement with MR was better for 3D than for 2D, as evident in the Bland-Altman plots. Although recommended by current guidelines, adoption of 3D into clinical practice has lacked in the past because of time-consuming analysis. More recently, an automated algorithm that measures left atrial and left ventricular volumes and ejection fraction had been validated. As shown on this slide, following initial fully automated detection of left ventricular and left atrial endocardial services, the software allows the user to perform manual corrections of the endocardial boundaries when needed in the center, resulting in final 3D casts of the cardiac chambers. The optional corrections are performed in anatomically correct, non-foreshortened 2D planes showing focused long-axis views of the left ventricle at the top and left atrium at the bottom, both automatically extracted from the 3D dataset. The accuracy and reproducibility of these 3D measurements were excellent. This is Dr. Wendy Tsang's work. Her study findings suggested that automated simultaneous quantitation of left atrial and left ventricular volumes and left ventricular ejection fraction is feasible and requires minimal 3D software analysis training. The automated measurements are not only comparable to manual measurements, but also to CMR. This technique is highly reproducible and is time-saving. How does 3D compare to 2D left atrial volumes for prediction of outcomes? This study of 116 patients had both 2D and 3D left atrial volume assessed. 3D left atrial volume performed better in the prediction of heart failure, hospitalization, and death. In summary, 3D volumetrics, based on data available, have greater precision, reproducibility, accuracy, and lower variability. There is no foreshortening or geometric assumption, and can now be fast and easy. 3D and 2D left atrial volumes correlate well with CT and MRI, but generally 3D performs better. For serial follow-up, you need to use the same modality. Let us shift our attention to left atrial function for a few minutes. This is classic figure of 8 volume pressure loop describing the 3 phases of left atrial function. When mitral valve closes, blood fills the left atrium and left atrial volume increases during this reservoir phase in yellow. In diastole, the mitral valve opens, blood flows into the left ventricle. This represents the conduit phase of the left atrial cardiac cycle in orange. At the end of diastole, just prior to the P wave, when the atrium actively contracts, this is the pump or contractile function of the left atrium displayed in blue. You can measure these phasic functions volumetrically. Reservoir function is most commonly assessed as total emptying fraction, which is calculated by maximum left atrial volume at the end of ventricular systole minus minimum left atrial volume at the end of ventricular diastole over maximum left atrial volume. Historically, we have measured these other parameters for assessment of left atrial pump function: peak A velocity, A wave time velocity integral, atrial fraction, A wave time velocity integral over total VTI, and left atrial ejection fraction. However, do recognize the fact that these are all surrogates of left atrial function by measuring blood flow during atrial contraction, and you can only measure these in sinus rhythm. Left atrial strain, on the other hand, measures specifically the actual myocardial function. Strain is a measure of myocardial deformation, basically the change in length divided by the original length. For instance, if we start at 10 centimeter, contracts down to 8 centimeter, the change is minus 2 centimeter. Strain is therefore minus 2 over 10, which is equals to minus 20%. There are 4 types of strain methods: tissue Doppler imaging, 2D speckle tracking, velocity vector imaging, and 3D speckle tracking. Tissue Doppler imaging strain requires high frame rate, 90 to 120 frames per second, and narrow sector angle. It is angle dependent. You can only assess strain for atrial walls, but not the roof. You need to track sample throughout the cardiac cycle, so it's very labor intensive. It's susceptible to translational motion. but it can measure phasic function. The most commonly used method is 2D speckle tracking. It is semi-automated, much simpler than tissue Doppler imaging strain. It recognizes ultrasound speckles during cardiac cycle and tracks how the speckles move to a different location over time. It requires frame rate of 50 to 70 frames per second. It's angle independent. It can evaluate both global and phasic left atrial function, and is dependent on 2D image quality. The third type is velocity vector imaging strain. It combines speckle tracking and endocardial border detection. It can apply to images from different vendors and can demonstrate magnitude and direction of velocity. There's already a meta-analysis of normal reference values for strain. The analysis had included 40 studies using 2D speckle tracking or VVI strain. Reservoir function 39.4%, conduit 23%, and contractile function 17% in the study. The most novel left atrial strain method is 3D speckle tracking. There have been some concerns about 2D speckles may not remain within the imaging plane, and that we need 3D to track speckles independent of the imaging plane. The current problem is that it has low frame rate and non-optimal spatial resolution. It also lacks standardization. But recently, there have been published normal values for 3D segmental strain as well. Left atrial strain, and in fact left atrial function in general, is a fascinating area. As our echo capability improves over time, where strain imaging is becoming easier, it will be highly valuable in a number of areas of investigation. This study, for instance, really highlights how LA strain is more sensitive to the detection of left atrial remodeling. All 421 patients in this study had normal left atrial volume, yet 29.4% had abnormal strain, which really speaks to it being probably a more sensitive marker for left atrial remodeling than left atrial size itself. I'll spend a minute on right atrial volume assessment. It is really simple. We use the 4-chamber view monoplane Simpson's method. Just like the left atrial volume assessment, we have to be very meticulous in making sure we don't foreshorten the right atrium. Normal for men is 25 plus or minus 7 ml per meter square, and for women 21 plus or minus 6 ml per meter square. The relative predictive capability of atrial volume and function is highlighted in this study of patients who underwent electrical cardioversion for atrial fibrillation. Atrial function is superior to atrial volume in prediction of maintenance of sinus rhythm. Right atrial function, measured as emptying fraction, was the most powerful predictor, followed by left atrial function, right atrial volume, and then left atrial volume. In summary, I still have to write this. Thanks.